Hello, friends, and welcome to Pharmacist Diaries, the podcast that reveals the secret lives of pharmacists, from where their journeys began, where they are now, and everything in between. Before we start today's conversation, I'd really like to take the time to say thanks. A thank you to all of you who have chosen to listen or watch the podcast, but also a thank you to all of my guests who have chosen to dive deep into conversation with me and share their professional and personal journeys. You guys have enabled me to embed creativity into my day-to-day life, and I'm so fortunate that I can share that joy and passion with you through this platform. This podcast has been a passion project of mine outside of my role as a full-time pharmacist, a mother and a wife. Everything you see and hear has been built in my spare time. In order for this platform to grow and provide you with insight into the lives of pharmacists, I really need you to hit that subscribe button. I am super excited for what's in store for 2023, and a lot of that will depend on the number of you that subscribe to the channel and tune in to regular conversations. Thanks again for all the support, and I'm really looking forward to the development of this podcast and our pharmacy community. Don't forget, my website is now live and up and running. You can access full show notes to all of my episodes and more at www.pharmacistdiaries.com. Make sure you subscribe to my newsletter so you can receive emails of upcoming episodes, free content, and regular inspiration. Now let's see what's in store for this week's episode. And we're good to go. So welcome to Pharmacist Diaries, David.
Hello.
Thanks so much for making time for me today, especially when you have a poorly toddler at home. I guess it's a nice hour of peace before you go back to the storm.
This is my respite time.
And thanks for making time for me on a weekend as well. I know it's precious time when you've got a family. So yeah, I'm grateful for that. We'll kickstart our episode with finding out why you became a pharmacist in the first place.
Yeah, so I grew up in Belfast, Northern Ireland. And at school, I always gravitated towards the sciences. My mum and dad kind of split. My mum went very politics and my dad went all sciences. So there was quite an influence there. So me and my younger sister gravitated towards the sciences, and my older sister gravitated towards languages. And even to this day, that still exists, where me and my sister are both pharmacists. So she practices in Northern Ireland in GP practice, whereas I'm obviously in community. Whereas my older sister, who ventured more along the humanity side, is a translator in Holland. So obviously the family split is still there. But in school, really loved biology, really into the sciences. And obviously at the careers talk with the careers person, it was like, what can I do with this love of science? Because pharmacy didn't run in the family. So she was like, well, you could do, because I was thinking do biochemistry or something that was linked to biology, because biology was my favorite science. And then she was like, oh, well, you've got medicine, dentistry, pharmacy. And so I'd applied for dentistry and pharmacy. Then I still wasn't 100% sure of what to do, so I took a gap year. And then the following year, I chose to do pharmacy at Queen's University, Belfast. And my sister, who's a year younger, also chose to do pharmacy, so she always says I copied her. So we ended up in the same year. Went through, did the undergrad, really enjoyed it. Belfast has one of the best pharmacy schools in the UK. I think it's always ranking in the top 3. Lots of really good things that go on, lots of good research, good links to the local hospitals. And then did my pre-reg year in community in Belfast. And this was about the time of, do you remember the credit crunch? It was
no, because I spent
2010.
I spent quite a lot of my teenage years and my first degree was in America. My
Oh,
parents like moving, so I wasn't around then. But yeah, go on, tell me.
yeah. So the credit crunch, I think it was around like Lehman Brothers in America, and Ireland had been a very fast growing economy. And then when this happened, lots of things shut down. That also affected the pharmacy side of things, and lots of my year moved to the UK. So lots of people in Ireland, Northern Ireland, went to like Scotland, England, and Wales. So when I first qualified, I moved to northwest England, moved to Cumbria, Lancaster, and loved it because I got to work in the Lake District. I worked in like like Windermere, all those little cutesy Lake District towns. So
That's amazing.
it was a lovely introduction to pharmacy life because it was just really, really quaint, really nice. The community was nice, and obviously, you'd occasionally get bits and pieces on tourism, but by and large, very nice little introduction to pharmacy. Um,
How was it moving to England for the first time?
yeah, very very same in Northern Ireland to England. Relatively similar setups. The only difference was like I worked in quite, I guess, a flashpoint area of Northern Ireland. It was a place in like northwest Belfast, so it does have a lot of layover from the Troubles era. So that obviously plays a part in some of the community pharmacy stuff. But then when I moved to Cumbria, because I'd moved with so many people, I could literally go to any city in England and know like 10 people. So we would have nights out in Liverpool and Manchester, Preston, Lancaster, Cumbria, like Scotland. I could go as far as London and know like 10, 20 people.
Oh, that's amazing. So you had your own little community, but scattered all over the country.
Yeah, so it was weird in that when I moved to England, I still only knew Northern Irish people. We hung about in big cliques all across England. Um, and then I moved. I think I moved down to Preston. There was a lot of us living in Preston at the time, and I worked in Blackpool as well. Blackpool, great city, great night out. And then I moved back to Northern Ireland. There was a time about 2014, 2015 when the economic scenario in Ireland had been picking back up again. And I thought, let's go back to Ireland. Let's see what it's like. Went back, didn't really enjoy it. I think England is a bit slightly more progressive in the things that we can do. They always tend to be a few years slightly ahead of Northern Ireland. I went back and I was just a bit like, not really sure I wanted to stay in community. So my mum, who was like, "Oh, you can't move away again," so she was like, "Oh, you have to stay at least for a year." And I was like, "Okay, I'll think about it." I said to her, "I'll do you a deal. I'll apply for one job, and if I get it, I'll stay, and if I don't, I'll move." And so I applied for a hospital pharmacy job, thinking I'll never get this. I was like, I'm no mission because it's not like in England because we have very few hospitals in Northern Ireland. So actually, the competition for those jobs is high. I remember applying for a hospital pre-reg, and the competition for it was fierce. I didn't get it, and I was never like the star pupil in pharmacy class. I tended to always run somewhere in the middle. But I did always have the passion for like the biology side of things. And then I applied for the hospital pharmacy job and got it. I still don't know to this day how I got it. I was like, okay, so because I'd already agreed with my mother that I would do it, I was like, okay, let's see what hospital pharmacy is like. I had no preconceptions. It was one of those things that I just randomly had seen. It was like on one of the internet job search engines in Northern Ireland, and I was just like, oh, let's see what it's like. Went in, absolutely loved it. Radical change to community pharmacy. Just really enjoyed like the clinical side, the academic side, and I also got to shadow like the HIV pharmacist. So before I didn't really have much of an idea of like the specialities that pharmacy could go into in hospital. So I'd already been a pharmacist for about 4 or 5 years by that point. So to see this like basically brand new world was quite eye-opening. And so I was like, oh, yeah, I just really want to pursue that avenue slightly more.
Your stars were aligned to live with your mum and be with family, which
Yeah,
is great.
for
And
that 1 year.
for the 1 year, but yeah, amazing that you found a way to transition from community to hospital, because it can be quite tough, and definitely in the years that you're talking about, it was quite competitive, and it still is challenging for community pharmacists now to transition over to a hospital role. I mean, the other challenge is the income, because you kind of feel like you have to start from the
Yeah.
bottom and work your way up. You've got the on-calls, which can be challenging if you've already worked for 10 years in community pharmacy. You do your 9 to 6. You may not even be doing weekends, and suddenly you have to do on-calls and rotations, and it's like a 180-degree change in terms of your routine. However, the learning experience and the change of environment, the fact that you need to adapt to different settings within the hospital on a regular basis, your communication skills, your ability to prioritize, there's so many positives. And it's not like you can't get that from community pharmacy, but when you switch quite early on in your career, it's quite, like you said, it's an eye opener. It's quite thrilling, because you're just learning at a fast pace again, and you feel like a student, but you're also making interventions left, right, and center, and making an impact to patients' lives very quickly and multiple times a day, whether it's looking at interactions or counseling a patient on discharge or identifying problems on a MEDSREC, like a medicines reconciliation, is a great opportunity to identify problems and solve them. And a massive part of our role as a pharmacist in the hospital. And it's, the start to the basic kind of interventions that we make. So it must have been quite exciting from that perspective as well.
Yeah, no, it was very different. Obviously, like pay when we look at healthcare as a whole, either UK or Ireland, like the pay is not, it's never in the same leagues as someone that works in private industries, finance, or whatever industry you work in. So, whilst the pay is different, and to be honest, it's taken a long time for me to actually get pay parity from what I was earning in community. It took me maybe like 5 years. But obviously, some of that will be personal choice in that I stayed as a 6 for quite a long time. But because I kind of knew what I wanted to do, I wanted the experience of those shorter rotations. I didn't want to spend 9 months in one area. I wanted to spend like 3 or 4 months in multiple areas. So I wanted the experience quite a lot. And I think sometimes that's probably a problem in maybe today's society. I see it in London quite a lot, where 6s, they're qualified for a year and they jump. They're like, I have to get to band 7, have to start earning more money. And then they get a 7, and then they're like spending 6 to 9 months in a rotation, and they're like, I don't like these rotations. And then they get a bit disillusioned with hospital, maybe because they didn't spend enough time as a 6. They only maybe done 3 or 4 rotations. They progress quickly. And, that I think some of them struggle. They get disillusioned. And then by the time they get to band 7, then they're like, I don't know if I like this. And then some of them fade away. They go into industry. They go into GPs. Then you see them might come back at a later stage. Whereas if it was me, I would advise people to stay as a 6 to experience a lot, and not necessarily in one area or like one hospital. Like try a specialist hospital versus a district general versus a large teaching hospital. Your 6 career doesn't necessarily have to be in one place. I think a lot of people are very focused on getting that next band.
Yeah, no, I've seen this quite a lot, and it wasn't something that I experienced as a band 6 personally. Well, I mean, I started in 2010, because I signed up for a residency and it was just an expectation to do the 3 years. Like there was no way you would really, it was rare to go to a band 7
Yeah.
within those 3 years. Like you kind of had to finish the residency in order to step up, especially where I was in Oxford. You definitely had to finish the full 3 years before you were eligible to apply for the band 7s. I really enjoyed my pre-reg year in a very small family-oriented specialist hospital, a very small pharmacy of less than 50 people, loads of amazing different rotations, and a lot of cardiology and respiratory. But then when I went to Oxford, you're in a massive teaching trust where you've got 4 hospitals. And the great thing about the rotations every 3 months is that you are switching sites. So you're technically working in actual different hospitals. So you experience what life is like in those settings. So Oxford, the main John Radcliffe Hospital, is really huge, lots of specialist areas, amazing rotations. And then you've got Banbury, which is a nice, like family-oriented hospital, like slightly outside of Oxford. People, when we rotated, no one really wanted to go there, but then when they go there, they totally love it because it's sort of chilled out compared to the normal crazy JR, as we called it. And then the Churchill was really specialist with all the CF patients, like the HIV, infectious diseases, TB, cancer. So you really immersed yourself in that kind of tertiary centre. So that variety was really useful. And doing the full years 3 years was useful because you got to see everything. And even then, I felt I didn't know what I wanted to do. I was like, I love everything. I don't know how to pick a band 7. By chance, I moved out to Dubai to live with my husband, so I didn't need to make that choice at the time. I know that when I left, I didn't know what I would do, because I loved renal at the time, but it was mainly because there was so much involvement in terms of education and counselling for patients, which is something I still love to this day. You're very valued in terms of the MDT. When you're looking after transplant patients, there's so many interactions and so much counselling to do. You're creating all these little plans for patients to go home with. You're having discussions with patients for potentially like an hour at a time. And they're ongoing long-term patients that you would then see in clinic. So in terms of career progression, I was like, oh, this is amazing. You get to know your patients, long-term. I didn't like the acute settings as much because it was just so fast-paced and you're making interventions all the time and you make a big impact. But I could tell that I just loved getting to know the patients. So that didn't really appeal to me as much. And surgery, I found it a little bit boring, and I feel really bad saying that because it's
Ooh.
not. But I didn't enjoy it. It is. I just felt like, it's just a constant like VTE and constipation and pain control. I was like this. It after a while, it just got kind of a bit of the same.
Yeah.
And as a band 6, when you do that day in day out on a ward. And you get so used to it, and you're not necessarily at the point where you're allowed to implement new services or get involved with, an MDT or a ward round because of the way the rotations work. I just felt like it was a little bit too much of the same on a daily basis, and I wanted a bit more variety. But yeah, it depends on what type of surgery. When I went to upper GI and lower GI and then got involved with PN, that became really, really interesting. And that variety really kind of helped me to understand so many parts of kind of like nutrition. So I did like that kind of surgical interventions, looking at colostomy bags and how pharmacy and medications impact that. That was really interesting. So as a band 6, you got the opportunity there. And yes, you're not earning as much money, but you're really getting to grips with understanding you as a pharmacist and what you're passionate about and what you could genuinely see yourself doing for a very long time. And I think that's a really kind of valuable point to put across to the younger generation who are going out there and looking for jobs at the moment or starting band 6 rotations, is that relax, your band 7 will come, and
Yeah.
you'll find that opportunity when you're ready for it. And don't chase the banding, and don't chase those numbers, or don't chase the money. Of course
I
we
would
need
say
money.
chase the passion.
Yeah.
Find, because money isn't, even between band 6 and band 8, the money is not ridiculous. It's small steps up in the grand scheme of things, and it'll make your life so much better when you find your passion. When you get to that band 8 where you actually like what you're doing, making going to work is a breeze, because you're like, I'm going into something I enjoy, rather than going into something you feel is burdensome, or like where you feel like you're just making interventions just because it's what you do, rather than what you enjoy to do. So I
And
would fully
also,
agree.
yeah, and also, for me, I left the UK and I went into leadership roles within, like, internationally. It was a huge change, an unexpected change. So my pathway in terms of becoming a specialist pharmacist kind of halted. It was a great experience to have that kind of chop and change and immersing yourself in a different environment. But then when I returned to the UK, it was quite challenging mentally, to feel like you have to relearn everything, because when you're a band 6 and you're a resident, you're literally a sponge for information, and you are very pretty much on top of your game in terms of the BNF and kind of understanding interactions, like looking things up. It's so easy for you to like quickly do an inquiry and answer questions. Everything kind of comes off the top of your head as well. But then when you kind of go out of that experience, you do gain a lot of transferable skills. You do learn a lot about yourself and kind of what you're looking for in terms of a career. But then when you come back to it, and I came back and applied for 8A jobs. However, my knowledge clinically, I had to study again. I had to really like go back to basics and relearn a lot. And the way that I did that was taking a part-time job as an 8A in education and training, as a pre-reg director. And then 2 days a week I locumed, and I chose to work back in Oxford. But I chose to work in emergency admissions, because immersing myself in this fast-paced environment with so many different conditions coming through the door, I knew it was a good opportunity for me to learn again, and basically make myself feel like a band 6 all over again in terms of improving my clinical knowledge and keeping up to date as to what the changes were. I was gone for 5 years, so a lot of things were different. So that was a really good learning experience. But sometimes I'm on a ward now, and there are band 7s who are teaching me, because when you change direction so quickly, it's difficult to then re-immerse yourself in that environment. But if you get to know what you love from the beginning, it becomes really easy to then go into the band 7 and go into the band 8 and really kind of immerse yourself in that specialist environment.
Yeah, I would probably agree. I would also say that with slightly moving around, it also benefits your network. It's meeting new people, especially because it was a bit like at school, when you had a teacher who would be really passionate about their subject, inspired you to like the subject as well. And sometimes when you meet interesting people and they're really passionate about their area, it can inspire you to like that area as well. So yeah, I would definitely be very pro networking, whether it's on LinkedIn, whether it's through your own current hospital, or a committee or a network that you've joined. Yeah, I would be very pro the building your network, and I think LinkedIn is good for that.
Yeah, no, definitely. So I guess you started your hospital job and you were really, really enjoying it. What were your thought processes in terms of career progression at that point?
So when I first started, I started in Belfast, and I was kind of, because obviously it was brand new to me, I was like asking the other pharmacists there, what do you do as a hospital pharmacist? How do you progress? basically asking all of those beginner questions because I'd never done a pre-reg in hospital, hadn't worked in the area. And they were like, well, most people will do the clinical diploma, but in Belfast, they only started the clinical diploma as a 7. And most people tended to be about a band 6 for about 3 years. Then they would move to the clinical diploma and do it as a 7. And the career progression there was slightly different to England, where I was like, I knew I was about 5 years behind. And I was thinking, oh, if I spend like 3-4 years and then I start the diploma, I was like, I could probably go back to England because I knew hospitals in England, they were offering diplomas as 6. And I was thinking I could probably just start the pathway slightly faster. And I had no qualms about moving back to England. So I decided after about a year, I decided I really liked hospital. I had a vague idea of what I wanted to do. Because basically in my 4th year project of my M.Pharm, I got to do a project in marine biology, which was very interesting because obviously it's not like your regular pharmacy projects that you get to do. And it was looking for novel antimicrobials in a marine environment. So I got to work with like a marine biologist, a PhD, and one of our pharmacy professors. So we got to go out to the beach, gather samples. So we had like crabs, sand, and we were growing stuff, culturing stuff from the marine environment, sending it off for PCR. Obviously, everybody knows what PCR nowadays is, but we were sending it off to Germany to look for these what bacteria we had grown, to see if there was any interesting chemicals in it. And one half of the project, at least for the PhD, was looking for novel antimicrobials that would combat Pseudomonas in cystic fibrosis patients. So what we would, because we had a link to the major hospital in Belfast, we used to get respiratory samples sent, and we target some of these things against the Pseudomonas to see if they had any activity. And the other part of it was looking for an anti-biofilm paint, so to paint on the ships the hulls of ships. Because in the maritime industry, I think descaling, or it's called anti-fouling, it costs like millions because as these ships travel throughout the oceans, they get like algae that grow on them. Stuff feeds on the algae, and then they become very heavy in the water. And then to get this stuff off, they had to physically go mechanically chip all of the like barnacles and algae and clean it off, and it's a very expensive process. Whereas if you could find a antibacterial paint to paint on the ships of hulls, like the biofilms wouldn't form. And obviously, if you get bacterial biofilms in a human, it also can be very hard to treat. So the Pseudomonas that grows in the lungs of cystic fibrosis patients, they're colonized basically lifelong. The same as if a biofilm grows on a metallic joint, can be there until the orthopedic surgeon takes it out. The same is kind of the same in the maritime industry. Once the biofilm is on the ship's hull, very hard to remove. So obviously we were looking for something that you could paint on a hull of a ship. It would be there. You might only have to repaint it. And so it was a very interesting project to do, and it kind of inspired me to look at the world of microbiology slightly more. So I'd already had that from my undergrad. And then as I'd like shadowed the HIV pharmacist in my first rotation, I was like kind of reinfused me to kind of look at the area. And as fate would have it, when I moved to Essex, my first flatmate was the antimicrobial lead pharmacist for the trust I was going to. So it was me, the antimicrobial pharmacist, and 2 surgeons. So I kind of felt like fate was telling me, David, you need to go back to microbiology. You need to go back to your original passion. And as a 6, I did the general 6 rotations. There wasn't antimicrobial rotations, but because I lived with the antimicrobial pharmacist, I got to see his job. I got to see the audits he was doing, his research. I got involved just because I wanted to, and also because we were flatmates and there wasn't much to do when we were living on site, because we lived on site of the hospital. So basically, we had to be friends. So all of the stuff we did together. So it was a bit of a trade-off in that, because I hadn't done on-calls before. So the trade-off was I would say, I'll buy the KFC for dinner if you help me with my on-calls. He was a big chicken fan. And obviously I learned loads from him. And when I think I spent about 2.5 years there. And when I decided to apply for a 7, I applied for a specialist 7. So it was in the world of surgery and antimicrobials. I would say for surgery, I can see what you say. But for me, like, if you see, everybody goes on analgesics, everybody gets dalteparin and enoxaparin, whatever it is. But it's like, it's those fine-tuned tweaks. Like, as an antimicrobial pharmacist, I kind of imagine myself, it's a bit like a chef. You're constantly tweaking doses. You're trying to kill specific organisms. So you might have to tweak doses of antimicrobials. You have to allow for renal function. You're a bit like a chef salting his food. With your drugs that you're using, you're kind of building recipes. So different bugs need different drugs. So you're kind of carefully selecting the right ones. And I guess the surgery is a bit the same. Okay, the drugs are the same, but for like analgesics, somebody might be an ultra metabolizer of codeine and somebody might be a very slow metabolizer.
No, absolutely. My perception of surgery is as a band 6 pharmacist, where we were still in paper drug charts and you'd be given 2 or 3 wards up to 90 patients, and you were literally a drug history, meds rec, TTO, queen or king running around. So you're doing a lot of the same tasks over and over again at such a fast pace that, of course, you can make amazing interventions even as a band 6. But when you are a machine in that respect, in a big teaching hospital like that, and the expectations for us were really, really high. There sometimes were 2 to 3 wards that you'd have to cover, and the expectation is you see every patient every day. So the amount that you can give to each patient is obviously limited. So from the perspective of making those little tweaks that you're talking about, absolutely, as you become a specialist pharmacist and as you transition into that band 7 and band 8, there is so much that surgery has to offer. But from my experience as a very junior pharmacist and learning about what I was passionate about, the educational side and the counseling side of pharmacy, I knew very quickly was, that was my passion, and that's kind of what I wanted to pursue. So yeah, everyone listening, like, surgery is not boring. There is so much that you can do with
want
it.
to reiterate that.
Yeah, David wants to clarify that it's not a boring pathway, and to put me down for saying that. But yeah, absolutely, there is a lot the surgery can offer, but when I was looking at my passions, that's one of the things that deterred me.
Yeah, because during my band 7, I did my independent prescribing. So I did my independent prescribing in prosthetic joint infections. Obviously, orthopedic, bit niche infection, and I linked it through OPAT service, so the ability to give patients in the community IV antibiotics. Generally, all of the complex types of infections, like managing Pseudomonas and cystic fibrosis, or managing infective endocarditis, managing prosthetic joint infections, long courses of IV antibiotics, sometimes cycling through different ones, combating resistance that might develop. And obviously, you don't necessarily want these patients in a hospital environment, because obviously they're at risk of picking up other hospital-acquired infections, especially during the pandemic. You don't want them picking up COVID. You don't want them picking up, C. diff. You want them to be in their own home environment. The district nurse can go around, generally administer 1, maybe 2 IV antimicrobials, and then you can complete 6 to 12 weeks. And that team environment, that OPAT team, is fantastic. I really love the OPAT setup. You get a microbiology consultant, generally an antimicrobial pharmacist, an OPAT nurse. Currently, we have 2 junior doctors on our OPAT team. And obviously, I get to train them as well. So it's their first experience of maybe managing infection in complex patients. And obviously, you get to open their eyes, and the microbiologist will maybe help them authorize screening. So on the pathology side, they can show when they're authorizing samples. So when blood cultures are taken or synovial fluid samples are taken, they're looking for the organisms, they're looking for the sensitivities and why they might pick certain antibiotics. And then obviously the stewardship side on using narrow antibiotics versus when you would use broad spectrum and those types of scenarios. And it's really good to see like the juniors, regardless if it's a nurse, a pharmacist, a doctor, it's really nice to see those people kind of develop and be like, oh, I really want to go into the world of infection, regardless of their speciality. I know like throughout my career, some of the like most interesting people have been other healthcare professionals. For example, when I worked at Lewisham in Greenwich, I worked as part of a diabetic foot MDT. And one of the best people that I worked with was a podiatrist. And she knew how to dose teicoplanin, probably more so than most pharmacists and the vascular surgeon, the endocrinologist. You know, she'd be going around on the diabetic foot ward and being like, dose of teicoplanin's too low, needs to be upped. You know, and it was like, I'd obviously spent a bit of time with her, explaining why we were using it, explained about TDM and levels, and she was just like a dog with a bone. She just absolutely loved to chase it down, had a real passion for the management of her patients, and obviously there were her patients, all these diabetic patients, and she just wanted the best outcomes for them. So she just took a real love for pharmacology and therapeutic drug monitoring, even though it was like probably not in her job description, but just had a real passion for it. So even when I wasn't there, she'd maybe send me a WhatsApp message to be like, David, this doesn't seem right. And she'd be like correcting prescriptions. And when I worked in intensive care for a bit, and I worked with a fantastic dietitian, and I'd obviously work quite closely with her in like the ITU MDT, as you do with a whole wide range of other specialities. But because I got to like impart some of the infection and antimicrobial knowledge onto her, and she would sometimes impart the bits about TPN and feeds. And so she'd spot like interactions between like ciprofloxacin and maybe feeds, and she would be like, you need to hold the feed 2 hours before that you're giving the Cipro. So she'd be, if I wasn't there on the ITU MDT, she'd be advising the ITU, the anaesthetists on the feeds mixed with the antimicrobial therapy. And obviously it was really nice to see that interplay of professions, because I think sometimes pharmacy can be, I don't know, sometimes pharmacy is a bit of the quiet man of the triangle. You know, we're often looking up to doctors, we're looking up to consultants, whereas really, like, I love being a pharmacist. That's my role. I'm a specialist in medicines. That's what we're told, you know, pharmacy, master of medicines. We're not a master of medicine. That's not our key aim. And I know a lot of some of the maybe junior pharmacists, they're looking up, they're aspiring to the senior consultant on the ward round. Whereas actually, now that we have consultant pharmacists, we are the role model. You know, look up to the consultant pharmacists in your region. Look at what they do. Look at the areas. Look at how they've developed themselves and their career. You know, own the profession. Like, stop focusing on learning as much as you can about pathophysiology and disease states. Go straight into the pharmacology. Learn everything you can about your drugs and how it interplays in everybody else's area. Because obviously, it's not just the doctors. It's like, how do you train the physiotherapist about pain meds? You know, in a surgical world, right before the occupational therapist or the physiotherapist is getting them up to do their exercise, telling them, by the way, the morphine's going to take an hour or two to maybe kick in. So you might want to tell the nurse before you get them up to do their post-hip operation physio, get the analgesics on board and they'll make your life so much easier. working with the dietitians and the antibiotics, working with the podiatrists in these complex diabetic feet. And obviously you're inspiring them about pharmacology. You're not necessarily telling them about disease states. You're telling them about drugs, which is our key speciality. And now obviously the interplay works both ways, and that the podiatrist will tell you bits about debriding the wound and wound management. And I find that has always been a real fascinating bit about healthcare. You get to learn so much from different things that you probably would never have thought about. Like growing up, I would never have thought, oh, what does a podiatrist do? But then when I see how they work, the types of things they get involved in, and if you get someone who's really inspiring, you can be like, oh, I really want to help you. For example, I'm working on a project at the minute with our podiatrist at Croydon. It's looking at diabetic foot infections, but the use of a product called Stimulan. I'm not sure if you're aware of it.
No.
So basically, Stimulan is just calcium sulfate. It's fine to implant. So orthopedic surgeons use it a lot during, maybe if you want to pack some dead space. So let's say you're putting an implant in and you cement it, and inside the cement you can put in antibiotics. Generally, it's like vancomycin, gentamicin. But let's say maybe you're dealing with a sarcoma, maybe like a bone cancer, and you have to cut away the margins of some of the muscle. And you don't want what's called dead space, because obviously then collections might form, hematomas, and then organisms come into that. You could pack the space with calcium sulfate beads, and the beads contain an antimicrobial. And you can obviously tailor some of these antimicrobials with the microorganism you're growing. So let's say even if you had a vanc-resistant enterococci, you might be able to put daptomycin in the beads, which would allow you to obviously locally treat the infection. And obviously you can have systemic IV antibiotics on board as well. But the benefit of the beads is they elute slowly over time, so maybe about 40 days. So you don't need to do therapeutic drug monitoring. You don't necessarily have to worry about it. Don't have to do gent levels or rank levels. They stay local. So I'm working on a project at the minute, and we're one of the first centres to do it, but it's basically packing diabetic foot wounds with these calcium sulfate beads. And in the beads, we're going to put antibiotics in them. And that'll basically allow us to get away from such broad spectrum systemic therapy. We can hopefully treat some of these wounds topically. Because obviously a whole push for the NHS at the minute is admissions avoidance. We're trying to get the flow through ED to be less. So people aren't picking up COVID, the flu, group A strep and ED. How can we circumnavigate the pathways, the normal pathways through ED? And obviously some organizations are setting up things like virtual wards where you get a consultant. It's a bit like OPAD, where you get a consultant on a team and they manage patients in the community. And obviously now that the technology has come on board, and I think obviously COVID had pushed some of this technological drive, to do Skype calls with patients, to have remote monitoring of vital signs. I think nowadays we're looking at, it's not just the traditional go to A&E, get treated, get admitted, get discharged. This service would be, rather than come into ED, come to see the vascular clinic, come to see the podiatrist and the vascular surgeon, the pharmacist, get the wound managed. We can pack the beads in some of these dead spaces and then be followed up in the community. And obviously, if they need systemic therapy, to link the vascular clinic with the OPAT clinic, because the OPAT clinic sits in hospital, but we manage community patients. We get a line in the patient, and we could treat them with IV antibiotics if they needed it. So obviously, you're bypassing the normal route of the flow. And also you can decrease your total antibiotic consumption. You're not having these people sitting on wards.
That is so interesting.
If you can manage everything topically. So there's even, I think Guy's and St. Thomas's have managed to treat osteomyelitis with these stimulant beads. I think they're one of the centres who have done some of the initial research. So the company that does it, it's like the first in the world. And it's the only product with a license for this. So obviously it's good to jump on board with these current things, current topical treatments and find all the ways you can to reduce your antibiotic consumption, because obviously antimicrobial resistance is such a risk.
Absolutely. And in terms of the project, where does the pharmacist sit in terms of their role? Like, what's the ideal situation if this project goes live with patients on a day-to-day basis?
So basically what the pathway will be that the vascular surgeon, the podiatrist, will identify patients through their clinic. They will recommend a treatment, so it could be with stimulant beads. It has to be prescribed. Samples will be taken and they will send the prescriptions to me. So it'll only be the antimicrobial team that will screen the prescription. I will look back through their microbiology history to see, have they grown a vanc-resistant organism, because I might have to tailor, because the standard tends to be vanc and gent. But obviously, if you've got an organism that's resistant to vanc and or gent, I might have to tweak it. And I will say, oh, you have to do this drug, or you have to do, and I'll give them the measurements, because it's not like, obviously it's not systemic, it's going into a little bead. So the doses tend to be like per 10 cc's of calcium sulfate. It's not the normal. And obviously I'll look at their allergy history and things like that. And I can give them decisions. And again, I can prescribe for them. Let's say the vascular reg isn't there, or the vascular consultant's busy. I could do the prescription for them to say, okay, the patient's coming in, let's say Friday. I can prescribe it, get it ready. You review it in the clinic. And then I would supply them with the vials that they need to make it up.
That's very exciting, because it's such a novel therapy, and to think that a pharmacist is getting involved with prescribing something so new and exciting is great. That's really a cool project. I'd love to hear more about that outside of the podcast. Like, that's amazing. Do you have a team of multiple pharmacists within antimicrobials now?
So just me. It's me and one man band.
Nice.
I do get a rotational 7 to support with OPAT workload, but I get involved in so much more. And I've everybody that's come, I've always tried to make them passionate about antimicrobials. I'm like, you will not leave this rotation until you love antimicrobials, or you want to leave hospital altogether. But yeah.
And the skills they get from this rotation are transferable to any patient, any ward, which is actually extremely valuable. And for you to put in all of that effort, they can take that knowledge away for the rest of their career, really, which is amazing. Obviously, you want them to go down the route of antimicrobials, but if they don't, you at least know that experience has been extremely valuable to their learning long term.
I think everyone, everybody does general med, everybody does surgical, there's some core ones. I would say everybody has to do infection at some point.
I completely agree.
It touches every single thing. It's one of the top threats to humanity, like antimicrobial resistance. It's going to be killing lots of patients. There's very few medicines in the world that you would use that affect the patients of tomorrow. It's a weird way to think about it, but I always think of myself as almost like a future clinician, in that the medicines I will use for the current patient affects my patient of tomorrow. So the tazocin I use in my patient today means I have to use meropenem for the next patient because of resistance. So when I'm making decisions, a lot of people are stuck in the fix the problem in front of you. Whereas my mindset is not necessarily the problem in front of me. It's the problem that's tomorrow, next week, next year, 10 years. I've always got like one eye on the future. And thus my attitude to today is, let's fix the problem of tomorrow by doing X today, even though sometimes X might not be the latest and best treatment, because obviously everyone wants the best for their patient. The consultant wants the best, the nurse wants the best. For most 99% of medicines, you're looking for the optimum treatment. You're looking for gold standard. And obviously, if you use meropenem, tyke, vanc for absolutely everybody, you'd be in such a dire position next week because you wouldn't have the best agents left anymore. And thus we want to be using the least best, if you were to think about it in that way, agents for today so that tomorrow is easier. Because I'm also thinking about my workload tomorrow, and I'm like, I don't want to be dealing with 10 VREs tomorrow or 10 MRSAs. I want to be dealing with none, because that's my workload still at the end of the day. And I don't want to have to go to 100 root cause analysis because of inappropriate antibiotic use.
Yeah, absolutely. Tell me a little bit about, I mean, you're a one-man band. So obviously the ownership in terms of antimicrobial stewardship falls in your hands. But and it sounds like you're involved with a lot of different things, and you've got a lot of interest in terms of OPAT, like you've enjoyed bone infections, you're getting involved with these really exciting projects. But what's your day-to-day like? What do you get involved with on a day-to-day? Because I think it would be fascinating for people to know, because it's very different to a normal, ward-based job or a clinic job where you're sitting and you've got a list of patients to see, or if you turn up on the ward, you identify your new patients, which patients are going home, and you see the people in between. What's your life like at the hospital?
I would say if you want to be an antimicrobial pharmacist, stay as a 6 and experience every area. You want to do general medicine, you want to do surgery, you want to do peds, you want to do medicines information, you want to do oncology. I would say cover the general basis, get your core clinical strengths in all fields strong as a 6, because that's your foundation. Because obviously, in the world of antimicrobials, your patients will be anywhere. There'll be an ITU, there'll be an A&E, there'll be an orthopedics, GI, there'll be sexual health, there'll be pediatric patients. You can't scrimp on any area. It's a bit like the A&E and AMU pharmacists, the ITU pharmacists. They have to have core foundational skills. You just can't get away from it. You'd be a very poor antimicrobial pharmacist if you had virtually zero surgical background. I just don't know how you would manage that well. Because, for example, in our OPAT clinic, 80% of the patients tend to be orthopedic. It's very heavy osteomyelitis, very heavy prosthetic metalwork infections. And if you had no background in it, you would really struggle to make significant difference for those types of patients. So I would say really good, strong core clinical. And then when you get to the 7, you probably want some ITU experience. Some really high level, I would say lots of acute medicine, good bit of ITU, like something that is very broad, that allows you to see a lot of different things in a short amount of time. Whereas if you stick to a niche area, like if you do 9 months of AMI, or if you do 9 months of aseptics, you see the niche bits or hematology, you only see the niche of that area. Whereas in A&E and AMU and ITU, you're seeing hopefully a whole swathe of different things. And you'll also hone your skills in a specialist area. Because when you come to do my job changes day by day. It's like you get calls about, oh, you've got a prosthetic joint infection on the surgical ward. 5 minutes later, you're asked to review someone in AMU with, it could be, oh, you've got a TB patient on respiratory. You've got to manage complicated therapeutic drug monitoring in a patient with infective endocarditis, with poor renal function. You need to know all your organ systems. You need to know all of the specialities, the various guidelines. And so obviously, the queries that you get day to day are vast and varied. So obviously, you need to be able to quickly switch hats from your surgical hat to your general med hat, to your oncology hat, to your renal hat. You have to be quite good at being able to switch quickly. And then obviously you've got the slower burn parts that are sitting on the background. You're building guidelines, you're looking at your resistance pattern locally, because it's like when you build guidelines for the treatment of heart attacks, your heart doesn't randomly grow a 5th chamber. It's not like you're having to try and manage a different organ every day. The guidelines stay the guidelines, relatively the same. year by year, decade by decade. Whereas antimicrobial treatments, like they change on a whim. What you use today isn't what you use in 6 months' time. And obviously we've seen that with COVID, like COVID treatments were changing almost every week. To keep on top of that was laborious. I don't know who was working at the MHRA at the time, but they were just like, fine, new guideline. And obviously to update those and into the trust practice took up most of my time. It was like, oh, the MHRA released this new guideline, have to build the system. And then obviously you've got things like antimicrobial stewardship ward rounds, so for us, we do a point prevalence audit every month. So every ward, we look at all antibiotic prescriptions. And then I look at maybe like the 3 to 4 lowest scoring wards. I will speak to the stewardship consultant microbiologist, and I was like, right, for the coming month, we will target these 4 wards. So we do like ward-based AMS, lots of education, lots of talking about, like, for example, if lots of UTIs are getting treated just straight off the bat with IV Coamox or Tazocin, or their urine dipping loads, being like, why were you urine dipping a 90-year-old patient with a catheter? It's not going to change your management. Maybe they're not sending enough urine culture samples. Maybe they're just starting too much broad spectrum antibiotics, going on. Doing that face-to-face education, basically it's networking at the end of the day. You're going there, you're meeting the consultant, you're meeting the junior doctors, and you're saying, right, we all have to get on board. We all have to be following the guidelines, and supporting them to be able to make those decisions, and also supporting the ward pharmacist to say, you need to be confident to stand up and say, look, I think it's time for an IV oral switch. Their CRP is down, haven't spiked the temperature in 24, 48 hours. It's empowering people to make sometimes the hard decisions. Because obviously no one wants to say, stop that antibiotic. And the pharmacists are like, they'll be like, oh, but I can't just say, tell them stop it. I'm like, why not?
It's quite hard, isn't it? Antimicrobial stewardship and getting that change. It's quite a challenge. Empowering people kind of changes the conversation here, because if you are giving them the information and providing them with that knowledge, you will hope that they could be a little bit more assertive and confident to say that, hey, these are the factors I need to look at. And they're all tick boxing to say you need to stop or change to oral. Like, let's try it, give it a go. But people are afraid to stop because they're afraid that this infection will come back, or they've made the wrong decision for the patient. And it's quite scary, which is quite an exciting part of your job, because once people do make those changes, whether it's nurses doing the right thing with urine samples, whether it's doctors making the right choices in terms of what to prescribe, when to make those changes, empowering pharmacists to help with prescribing or clinically screening, it's quite rewarding from your perspective to see that you've empowered a whole team effectively to make better decisions for patients.
Yeah, definitely. I would say.
But it's hard work.
If you can digitalize your system, my big problem is I tell a junior doctor one thing and they rotate, and I tell the next junior doctor the same thing and they rotate. If you can build your system design so that the system tells them what to do, the basics, not the complex decisions to be made, the basics. If the system guides you along a route to say, why don't you do X? Decision support, to support junior doctors to make correct decisions. So, for example, when somebody prescribes an antibiotic at our trust through Cerner, our EPMA system, I've built it so that when you click the prescription, right on the second tab, so on the same screen, you pick the prescription and all the related results according to that drug is displayed right beside the prescription. So you get to see the temperature, the weight, the renal function, the CRP, the white cell count, the NEWS2 score. Yeah,
the basics.
So basically, you click that prescription, you see everything. But what I have also done is I tailored it by drug. So for gent, you also see the last gent levels. You also see the ideal body weight. So you can see the exact things that are linked to that antimicrobial itself. If you were to prescribe daptomycin, it also gives you the CK level. And if I click it and I don't see a CK level, I know they haven't requested it. So straight off the bat, it's the simple things that you can do to make everyone's life so much easier. And so a lot of people are like, oh, David, I love how you built this because I don't have to trawl through 5 screens. Yeah, I don't have to find the weights in one area, the renal functions in another area, the TDMs in another area. So whilst IT systems, I think, are so much better than paper, if you don't build them efficiently, you end up wasting so much of your day. Whereas if you can build it so that it's actually time saving, like that one click saves me about a good 10 minutes of trawling through.
Absolutely. That is really exciting, David. I love it because I love anything digital, and making life efficient and time saving is my jam. Like, I'm all over it at work. I love that kind of stuff. So hearing that, if I was the ward pharmacist, I would be so happy right now to have all that information at your fingertips. Like, literally. Oh, that's amazing. Love it.
We also have built our very own infections app. So one of our microbiologists is actually has a computer science degree background, and actually runs coding for junior doctors. So between me and him, we have built our very own, in effect, like a micro guide, but it's tailored specifically for us. And we've built it exactly how we want it, with decision support. And my idea is, I just love all things digital. For me, I would love that in systems, and I think this is a way off, but we have a potential project that's going to be looking at AI, so artificial intelligence, looking at, let's say, some metadata. Let's say we always know that vancomycin TDM is always poor, for reasons of weight, renal function, people in AKI and sepsis. If we could build a system that funnels a load of metadata in, so let's say 1,000 patients all on vanc TDM, and you get your next patient in, and the system says, for this patient's weight, they've got sepsis, they've got AKI, this is the dose you give, and this is the expected maintenance dose. But let's say the renal function goes up, the system would tell you what to do. And it would be to drive, rather than having the antimicrobial pharmacist to say, renal function's improving, that means your clearance is that means if you're treating a complex infection and you need the level between 15 and 20, you need to up the dose. And then obviously things go a bit haywire and you spend a couple of days tweaking. If you could build a system that can track things in real time and provide decision support in real time, like that's where the future is. I would say it's not going to replace antimicrobial pharmacists. It's going to be an adjunct. It's going to be a tool in their armory. That I think I could do this probably at present is rather than prescribing by drug, I would prescribe by indication. So rather than prescribing amox and doxy for CAP, I would type in my prescription CAP, and I get CURB score 0, CURB score 1 to 2, CURB score 3, 4, 5, whatever it would be. And the computer would actually tell me what the CURB score was because it's got all the relevant markers. So the system would tell me, your patient's coming in, you've diagnosed CAP, the CURB score is 5. This is the choice. Present you with the choice. Rather than your consultant saying, patient's got a CAP, give them IV Coamox. Yeah? Rather, you would have the consultant say, the patient's got a CAP, look up the system, work out their CURB 65 score, get them a chest x-ray, and prescribe as per the guidelines. And the guidelines are inbuilt in your system. Yeah.
Do you think there's a fear that relying on the system, I love everything digital and I love what you're saying, but it reduces the clinician's knowledge because you're relying on what the algorithm's telling you what to do?
No, I would say it's only an added tool, because obviously if you don't, I despise 50-page guidelines. You know, those hard PDFs, they're like 50 pages of a Word document. Who reads that? Like
No.
who sits down for the bedtime reading and reads a 50-page antimicrobial guideline? If anybody does, I want to meet them. You're probably the next antimicrobial pharmacist I need. But like, by and large, because obviously junior doctors, they're coming in, everything's fresh to them.
Yeah.
An infection is just one little piece of freshness in amongst a whole sea of baffling info. And it's not just the drugs they have to worry about, it's the scans, the bloods, the dealing with every single clinician. That's widespread responsibility. You know, so obviously I need to be able to support them to make good decisions as if I'm on their shoulder telling them information that they need to know. I don't want them to be spending time reading 50 pages of a document to find what they need, to interpret, to calculate severity scores. I want to make their life as efficient as possible, because obviously if I get prompt treatment for the patient without the need for someone to have to go away and think or speak to me, I want the decision support tool to say, David would probably say this is the ideal, or if you can then build it to say, this is a complex scenario, speak to X, contact X. You know, so that the system would be smart enough that it would tell you when you can and can't do a certain activity. So for all of our like restricted drugs, I have restricted power forms to say this is restricted antimicrobial. You know, this is the parameters in which you can prescribe. Do you tick it? Yes, no. And it's all yes, no. It's not a barrier to prescribing. It's a warning to say you are about to prescribe this. What's the indications, etc. And that gets saved in a form. So obviously I can audit all the forms and see their clinical appropriateness. But it's a support to say you're going into an area that's complicated. You know, if you need support, here's the contact details.
Absolutely. And that's really good. Like, that's a start, obviously, in the right direction. And in the case of antimicrobial stewardship and what you do as your job, like every day you're making progress from what it sounds. And there's a lot of exciting things that are coming up. And I'm sure a lot of people will be really excited to hear kind of your journey. And I'm sure there's so much other stuff that you do as well. I guess when it comes to your career and your role in terms of what you're doing at the moment, where do you see yourself going in the next sort of 5 to 10 years? Outside of this whole, research, looking at novel therapies, and the digital world. Like, I can see that you're really interested in quite a lot of things that kind of make life more efficient and easy for prescribers, time saving, increasing productivity. Looking at like the educational side of antimicrobial stewardship. But outside of that, I feel like you might have some other ideas.
Yeah. Well, I'm due our second kid in June.
Amazing.
So obviously that's going to suck up a good bit of time.
Fair enough.
I am a huge proponent of shared parental leave. I am very strongly passionate about men taking not the 2 weeks, taking a long, substantial time to be with their child and build that, because you don't get that time back. Obviously, I could say, I'm a one-man band. I need to be at work. The patients need me. Now, I could have that attitude like most men. But actually, for my first child, I took 3 months at the start and I took 3 months at the end. So my partner did 9 months and I did 6 months. And obviously, you'd have to take a hit somewhere. You have to take a financial hit. But to be honest, when it comes to things like family and that time, you do not get that time back. The bond that you create with your child in that time is, it's invaluable. You can't put a price tag on it. And obviously, looking at things like that, it's a no-brainer for me. But actually going through the process, whilst I was actually supported in my work, so currently when I did that, I was at Croydon. Very supportive by my line manager, very supportive from the team. But see, when I came to do the HR bit, it was like, oh, we've only had like 2 people that have ever done this.
And your point is?
Yeah, exactly. I was like, in a hospital of thousands of people, I think the shared parental, because basically you can take some of your partner's maternity pay And if you're taking shared parental leave, you can get some of that as well. And they're like, I've only had like 2 people ever do this. I have to find the policy. And it took such a long time to figure out how to do it. And in the end, they actually paid me wrong. So they still made an error, and I still got paid incorrectly. And it's like these little annoying barriers, and I was like, that shouldn't happen. This should be a very clear, straightforward process for men to spend and take time off and be allowed and supported to take that time off. We only have to look at the Scandinavian countries.
Agreed.
Sweden,
they've got
and Norway.
It covered. Yeah.
And I'm like the mother in like Sweden gets like 2 years, and it's like almost full pay. I was like, what? Like here, women get like 6 weeks, and I'm like, 6 weeks. How is a mother like?
It is extremely
ridiculous,
challenging. I mean, I've got 2 kids now. I've literally returned to work, obviously, this week, as you know. With Liliana, I was living in UAE, and I got 6 weeks maternity, and I went back to work 48 hours a week, night shifts, weekends, like machining. And I guess at that time and in that point of my career, I was very driven and kind of career focused, and I didn't have the mindset that family came first. Of course, you do have the mindset that family comes first, but I was also so career driven that I was like, well, I need to do what's right for my job, and the baby will fit into my life. And I accepted that. And I was like, this is, what's normal, I guess, or what society's telling me I should do and what they've offered in terms of maternity leave. So I have to accept that and get on with it. So she went to nursery. She absolutely loved it. But I, didn't see her very much. And that has impacted her emotions in the long run. She's very attached to me now. She's 5 years old. But, even in this experience of me being home for maternity leave and returning to work has triggered some anxiety in her, because she's upset that obviously I'm going back into full-time working right now. Yeah. Obviously, I've had the option with the NHS to take a full year of maternity leave, but financially we felt like I really needed to return early with everything that's happening with the economy, and our mortgage is due at the end of the month, and we just felt
like the interest rates going sky high.
Yeah, my husband is changing jobs, so from our kind of home perspective, we needed a little bit of security. So I'm returning to work, but I'm kind of returning on my terms. And I've been quite assertive, and I'm sure my line manager and my employer will agree, that I was quite adamant that this is what I need to be happy. This is what I need to enjoy my home life. And if I can be happy in my home life, you will see the best version of me as an employee. Like, this is how I feel. This is what you're going to get in terms of the best version of me as an employee, and I will give you my all. But my home life comes first. So I am eventually going to be returning to 4 days a week instead of 5. 2 days at the university, and then 2 days with the pediatric palliative care team. And I negotiated 1 day from home. And it was really important for me to have that 1 day at home so that I could have breakfast with my family. I can pick up my kid from school. I can spend the evening going to her swimming class and having that quality time that she looks forward to and that I look forward to. And there is that balance of not just being a machine all week and waiting for the weekend. There needed to be enjoyment in the week in terms of our routine, and I needed a bit of respite. And you're right, like, it is so challenging to get this balance right, and the world is making it very difficult for us to be good parents and be good employees at the same time.
Yeah, I work 4 days a week because between me and my partner, we don't want our child to be in nursery 5 days a week, and for both of us being super busy. And my partner is actually the higher earner between us. She works in finance. And she chairs her ESG committee in the world in which she works, and quite an influential female leader. And she when she has to take maternity leave, the partnership is actually skewed, and that the female that takes the time off, we are more financially affected because it's the woman that has to take the maternity leave. Whereas actually, why should that be the case? Because I know the argument traditionally is always like, oh, the man's the higher earner. I have to stay at work because I'm the higher earner. But actually, what if when the woman's the higher earner and you want to go back to work early, and there's like the cultural stigma? And to be honest, I have experienced it myself, where it's like, why doesn't your partner want to stay home with your child? And I'm like, because we got bills to pay, we've got a mortgage to pay.
And also, I want to be at home with my kid.
whilst the NHS obviously pays me bucket loads, I'm not the main earner here. It's my partner, and my partner needs to go back to work. And like, I am fully supportive of women that, regardless of when they go back, it's on their terms. They say, I want X. Can you satisfy this condition? Because obviously, it's like you say, you will be the best version of yourself if you get something that fits to what you personally want. And so for my partner, she'd go back 5 days a week, because in her industry, it's just not feasible. She might have to close clients' deals. She might have to be at their beck and call. She can't just have 1 day a week where she's like, somebody else can take it, because obviously the network and the relationship she builds with these investors, they need to be able to contact her. And I appreciate that. And that's why I take the 1 day off. So I do the childcare. And I'm completely fine with it. But obviously, in work, my deputy has to pick up the slack, and she has to become the 8A for a day. And no doubt tears her hair out for Tuesday. And she's just like praying for me to come back on the Wednesday. To be honest, I do say, if there's any problems, just WhatsApp me. Completely fine. Coco Melon can take a 5-minute breather for me to pick up some pressing prosthetic joint infection query. So I'm such a huge advocate for both women and men to basically be allowed to do what they want. Because some of the argument is like, the woman's like, oh, I'm taking a full 12 months. And I'm like, does your partner want any? And she's like, oh, well, like,
I never asked.
Oh, yeah, I never asked. And it's like, I'm the mother, I'm taking it. I'm like, have you even asked him what he wants? And they're like, it's like, it's just traditional and cultural perspective.
Yeah,
Whereas
absolutely.
For me and my partner see each other as a team. We basically sat down and said, what works for us? Like, I wanted some time off, especially because it was a pandemic. And I was like, I've worked ITU, COVID. I've worked in, the darkest of darkest scenarios. It's grim. I want some personal time. I want some breathing space from
absolutely
before I get burnt out. And I really love my job. And I was like, even this is like OTT. I need a break.
Absolutely.
So that just.
So I guess 2023, you'll hopefully be getting some respite.
Yeah.
And enjoying family time and life with 2 children, which, by the way, is a game changer in such a fun way. There have been so many amazing moments to see your kids bonding and enjoying spending that quality time together. I've got, obviously, Lily's 5, so she's very responsible and caring, and you can, the age gap is amazing because she is like a little mini mum. She can stop him from crying. She helps me with feeding him in the back seat. She helps to put him to bed. She has a bath with him, and she's literally washes his hair in a very terrible way, but she washes his hair.
So cute.
Yeah, my son has a ridiculous amount of hair, like for a baby. So she, is pouring water on his head, and he's literally can't even breathe. The poor guy, he's freaking out. But, it's magic. It's magic. And the 6 months that I had at home was magical. Like, I really did enjoy it. And it's not that I didn't want to go back to work, because I absolutely love what I do. And this week has been so overwhelming and exciting and exhilarating, rewarding, like everything emotional has kind of come up for me. So I do hope that my routine improves over the next few weeks. But I've been quite fortunate that my employer has let me use my accrued annual leave weekly. So I have shortened my weeks to begin with up until June, which is amazing, because I do then get kind of a couple of days at home in the week, and it's an easier transition into the crazy life of being a hospital pharmacist.
Yeah.
And there's a lot of enjoyment to come from that. I've taken up a lot of your time, I've just realised, and I've really enjoyed our conversation today. Thanks again for making the time and also sharing so much insight into what your role is at Croydon and what you've been up to over the last few years. And of course, I wish you all the best with the second baby and your family transition. Let me know how the whole parenting situation works out in terms of HR. We'll catch up soon.
Well, thank you.